Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Welcome back to the deep dive. Today we're shifting gears pretty significantly. We're leaving the clean, totally predictable world of the outpatient clinic. We're bypassing the orderly schedule, the elective OR, and we are heading straight into the chaos of the night shift.
That's right. We are going deep into the intensive care unit. And specifically, we're focusing on that really high-stress, high-adrenaline moment of the emergency intubation.
Yeah, you know the exact vibe we're talking about. It's 3:00 a.m. The alarms are blaring, that specific piercing red alarm that just cuts right through your soul. The patient is crashing. Maybe they're profoundly septic. Maybe they've had a massive stroke, or they're in florid heart failure. But they need an airway, and they need it right now.
It's controlled chaos. You have your team assembling, the nurses are drawing up induction drugs, the respiratory therapist is right there at the head of the bed, and someone slides an airway box in front of you.
And inside that box, in that exact moment of massive cognitive load, you have a choice to make. Or, well, more accurately, a choice has usually been made for you by your hospital's supply chain committee like 3 years ago. You're reaching for a piece of plastic that is going to sit in that patient's trachea for days or even weeks.
Right. And generally speaking, you are looking at one of two contenders in that box. You have the incumbent, which is the standard PVC endotracheal tube.
The Ford F-150 of the ICU.
Exactly. It's reliable, it's cheap, we've used it literally since the dawn of modern critical care.
And then you have the Challenger, the fancy tube, the one that comes in the slightly sleeker packaging.
The Cadillac. I assume you're referring to the endotracheal tube with the polyurethane cuff and the subglottic secretion drainage port.
Oh, yeah. The Cadillac of plastic straws. It sounds expensive just saying all those syllables out loud. But the promise of this device is massive, isn't it? It promises to solve one of the absolute oldest, deadliest, and just most frustrating problems in critical care. Ventilator-associated pneumonia, or as we usually call it, VAP.
VAP. Truly the bane of our existence.
The clinical question we are exploring for you today is simple, but the answer have these massive implications for our patients and for hospital budgets. In the absolute chaos of an emergency intubation, does reaching for that fancy tube actually save lives? Does it actually prevent pneumonia? Or are we just buying really expensive plastic with, pardon the dad joke, aspirations of doing better?
Aspirations. I see we're starting early with the puns today.
Look, I can't help myself. It's a coping mechanism for the ICU environment. But seriously, to answer this, we aren't just sitting around speculating. We have a massive new stack of evidence to unpack for you. We have the PreVent 2 trial.
Published in the Lancet Respiratory Medicine in 2025.
Yes, this is a heavy hitter.
It is a landmark trial for airway management. And we are pairing it with a very spicy editorial by Klompus and Branson titled Time to Pull the Plug on Subglottic Secretion Drainage, which really suggests the mood in the room is shifting significantly on this topic. Plus, to really understand how we got here, we need to look back at the historical context with the Deem et al. Pilot study from 2016 in the Annals ATS.
So we have the data, we have the history, and we have the controversy. Let's dive right in. But before we get to the p-values and the confidence intervals, let's just set the stage at the bedside for a minute. Why do we even care so much about the specific tube design? I mean, a tube is a tube, right? It keeps the airway open so we can push oxygen.
Yeah.
Why is the tube the villain in the pneumonia story?
It's a really great question. To understand why PreVent 2 is such a big deal, you have to understand the basic mechanics of VAP. When you intubate someone, you are essentially bypassing the body's primary fortress, which is the glottis.
The vocal cords.
Right. Normally, your vocal cords close tightly to protect your lungs. You cough, you clear your throat, you swallow. You have these amazing, highly evolved biological reflexes designed solely to keep junk out of your lower airways. But when we place an endotracheal tube, we are literally propping that protective door wide open 24/7.
It's like leaving the front door of your house wide open during a massive dust storm. And in this case, the dust is that really toxic slurry of saliva, oral bacteria, dental plaque, and gastric reflux that just constantly pools in the back of the throat.
We call it subglottic secretions, which is a very polite, sterile clinical term for what is essentially a pool of bacterial soup sitting in the patient's airway.
And gravity just does the rest of the work. That gunk sits there, right on top of the vocal cords, and it pools on top of the inflated cuff that's the balloon at the end of the tube that seals the airway. Now, the standard tube uses a cuff made of PVC, polyvinyl chloride.
And here is where we run into a major physics problem. PVC is a relatively thick, stiff material. When you inflate a PVC cuff inside a trachea, which, remember, isn't a perfect smooth circle, it's shaped sort of like a D or an oval, and it has these cartilaginous ridges, the plastic just doesn't conform perfectly to the anatomy. It bunches up.
Like putting a stiff plastic tablecloth on a round table that's just way too big. You get these rigid folds.
Exactly. It creates these tiny longitudinal folds all along the edge of the balloon. We call them microchannels. And through those microchannels, that bacteria-laden fluid slowly, continuously trickles down past the cuff and straight into the sterile environment of the lungs.
It's basically a slow-motion oil leak into a pristine ecosystem.
That right there is the primary mechanical mechanism of ventilator-associated pneumonia. The bacteria migrate down the outside of the tube or straight through those channels around the cuff. They establish a beachhead colony in the lower lobes, and then they aggressively invade the lung tissue.
So when you look at it that way, the engineering solution seems super obvious, right? Just build a better mousetrap, or in this case, build a better cuff. And that's exactly where the fancy tube enters the chat. It has two main, highly engineered upgrades to fight this specific war. First, the material itself.
Right. The engineers switched from PVC to polyurethane. Polyurethane is incredibly thin. We're talking microns thick. The working theory is that because it's so ultra thin, it doesn't fold or bunch up like the thick PVC when you inflate it. It drapes. It conforms perfectly to all the microscopic nooks and crannies of the tracheal wall.
So it's like saran wrap versus a thick hardware store tarp.
Ideally, yes. It creates a hermetic, flawless seal, no folds, no microchannels, no leaks.
And then the second major upgrade is the gadgetry attached to it. The subglottic secretion drainage port. We just call it the EVAC system on the floor.
Think of it as a built-in sump pump. It's a separate, dedicated lumen, a tiny little tube molded directly into the side of the main breathing tube, and it opens up just slightly above the cuff. You hook the proximal end up to continuous wall suction in the room, and it sits there, theoretically constantly slurping up that pool of toxic secretions before they ever have a chance to leak down into the lungs.
I mean, it sounds brilliant. In a vacuum, it's perfect. You vacuum up the mess, the lungs stay perfectly clean, the patient doesn't get pneumonia, they get extubated faster, and everyone goes home happy. It's such a compelling, logical narrative that a lot of hospital systems have basically made these tubes the absolute standard of care based purely on that biological plausibility.
Yes, but biological plausibility is a very powerful drug in medicine. It's so much intuitive sense to our human brains that we just assume it must work in practice. We sit there and think, how could sucking the bacteria out not help the patient?
But as we continually relearn in evidence-based medicine, should work and does work are two very, very different things. And there's a real tangible workflow cost to these devices, isn't there? It's not just magic plastic. You don't just put it in and walk away.
Oh, the workflow implications are huge. And I really want to take a second here to shout out our respiratory therapists and bedside nurses, because they are the ones actually dealing with the physical reality of this hardware shift after shift. It's definitely not plug and play.
Right. You have to physically hook up the suction to the wall canister. You have to make sure the pressure isn't set too high, or you'll literally vacuum damage the tracheal mucosa. But you have to make sure it's not too low, or it won't even pull the thick secretions up the tube.
The study protocol for PreVent 2 was actually very strict about this specific workflow. They required continuous suction at exactly minus 20 millimeters of mercury.
Why that specific number? Why minus 20 and not minus 40?
It's essentially the Goldilocks zone for tracheal suction. If you go much lower, say minus 10, you often can't overcome the sheer viscosity of the mucus. It's too thick, so it just sits there blocking the port. But if you crank it up to minus 40 or minus 60, the vacuum force is so strong that you risk sucking the delicate tracheal tissue right into the tiny porthole.
Which causes what we call a suction biopsy, which is definitely not something you want happening inside your patient's windpipe.
Exactly. It causes focal ischemia and necrosis. So the RTs have to constantly monitor this wall regulator. And on top of that, they also have to meticulously monitor the cuff pressure itself. In the trial, they were required to check it every 4 hours, explicitly targeting 25 millimeters of mercury.
Which is fantastic in a highly controlled trial setting, but in real life,
Yeah.
at the bedside, that tiny suction port gets clogged constantly with thick mucus or dried blood. Or it gets physically stuck against the side of the tracheal wall. And when it's functioning, it makes this incredibly loud slurping sound. You definitely know the one that just drives everyone in the room absolutely crazy at 3 a.m.
It really is the background soundtrack of the ICU. Slurp, slurp, slurp.
Yeah. As I always try to remind the residents, suction is like insurance, boring until it's everything.
Yeah.
But if that port clogs, and we've all seen this happen, if a well-meaning nurse or family member turns the suction off because the slurping sound is keeping the patient awake, then you're just left with a much more expensive piece of plastic that isn't even doing its one special trick.
Right. So that completely sets the stage for the clinical dilemma. We have a highly engineered device that theoretically solves the purely mechanical problem of microaspiration. We have years of previous smaller studies and even some robust meta-analyses suggesting it might reduce VAP rates significantly. Some of the older literature claimed relative risk reductions of as much as 40 or 50%.
Which would be absolutely massive. I mean, if you could literally cut VAP in half just by changing out a $40 piece of plastic,
Yeah.
that's a Nobel Prize level intervention in the critical care space.
It would be massive. But, and this is a very big but that we always have to watch out for in the literature, most of those previous highly positive studies were conducted in elective surgical patients. We are talking about people walking into the hospital for a scheduled coronary bypass graft with pristine, clean lungs being intubated in a highly controlled sterile or R setting by a rested anesthesiologist. We really didn't have a large-scale, rigorous, randomized trial in the most chaotic, messy setting of all, which is the emergency intubation.
Enter PreVent 2. This is exactly the study we've been waiting for to answer this real-world question.
Right.
So let's break down how they actually set this up, because as anyone who works the floor knows, doing a proper randomized trial right in the middle of a code blue or a crash airway is not exactly a walk in the
No,
park.
it is a complete logistical nightmare for researchers. Just getting informed consent is a massive ethical and practical hurdle. So this was a phase 2 randomized controlled single-blind trial. It took place at 2 major academic centers in the U.S. Oregon Health and Science University and Yale New Haven Hospital.
2 incredibly well-respected heavy hitters in the critical care research world.
Definitely. They managed to enroll 1,068 adult patients. And the key here, and I really cannot stress this nuance enough for you listening, is the specific population. These were totally unselected emergency intubations.
Let's just pause on the word unselected for a second. That means the researchers didn't cherry-pick the neat, tidy patients who looked like they were going to survive anyway, or the ones who had a perfectly clean pair of lungs on their admission chest x-ray.
Correct. The criteria was basically, if you needed a breathing tube right now because you were in acute respiratory failure, whether you just rolled into the emergency department or you're crashing upstairs on the medical floor, you were eligible to be randomized. This wasn't a curated elective cohort. These were very sick, highly unstable, undifferentiated patients.
The classic night shift cohort. The massive sepsis, the multi-trauma, the intentional overdose, the catastrophic GI bleed.
Exactly those patients. And the actual randomization process at the bedside was remarkably clever. To maintain blinding as much as humanly possible in a physical device trial, the study tubes were packaged inside these opaque, sealed envelopes.
I honestly love this practical detail so much. Just picture the scene in your head. The patient is visibly gasping, the oxygen stats are dropping into the 70s, you're yelling for the induction drugs, the adrenaline is just absolutely pumping through the room. You have 2-hand mask seal. 1 hand is optimism, 2 hands is reality, trying to bag this patient. You finally reach for the airway equipment, and you literally rip open this sealed envelope. Only then do you actually know which tube you're going to be putting through the cords.
It forces the randomization to happen at the very last possible second, completely removing operator bias. So you rip the envelope, and you either got the intervention, which is the PU evac tube.
Just a super quick pronunciation note for everyone listening, that's PU evac. I know it sounds a little bit like something a kid says when something smells terrible, but it stands for polyurethane and evacuation.
Thank you. Yes, the PU evac tube. Or,
Wrong.
alternatively, you got the control arm, which was just the standard, cheap PVC cuff tube.
Okay, so once the tube is secured And as we always say, secure the tube like it owes you money. The trial clock officially starts. The intervention group got their special suction port hooked up to the wall, explicitly aiming for that -20 continuous negative pressure. The control group just got standard routine care.
Yeah.
And then the research team simply watched them. What exactly were they looking for as the primary outcome?
This is where we have to step into the evidence nerd corner for a moment, because how we define the outcome matters immensely here. In the old days of critical care research, VAP studies were notoriously messy and controversial because pneumonia is actually a surprisingly subjective diagnosis at the bedside.
Oh, totally. It's the classic ICU Rorschach test. If I'm an optimist and I look at the morning chest x-ray, I say, oh, that's just a little bibasal or atelectasis from lying flat. If I'm a pessimist, I look at the exact same film and say, that's a new raging lobar pneumonia. If I decide to aggressively bronchoscope every single patient who spikes a low-grade fever, I'm absolutely going to find a lot more bacteria than if I just watch and wait clinically.
Precisely. It introduces massive surveillance bias into the data. So to completely avoid that subjectivity trap, PreVent 2 utilized the CDC framework for ventilator-associated events, or VAE. This is a very rigid hierarchical system of objective badness.
Okay, let's carefully unpack this hierarchy for the listener because it's not necessarily how we talk to each other during morning rounds, but for modern research, it is the absolute gold standard currency.
It starts at the very bottom of the funnel with VAC. That stands for ventilator-associated condition. That's a purely objective mathematical metric. It just means the patient was physiologically stable on the vent, and then suddenly they objectively needed more respiratory support. Their PEEP setting had to go up, or their FiO2, their fraction of inspired oxygen, went up, and it stayed up for at least 2 consecutive days.
So translated to the bedside, the lungs objectively got worse. You had to turn the dials on the machine up. That's step 1.
Right. Then step 2 is IVAC. That stands for Infection-Related Ventilator-Associated Complication, pronounced IVAC. That is simply a VAC plus signs of a systemic infection. So the ventilator settings went up, and the patient now has an abnormal temperature or a weird white blood cell count, and a clinician physically ordered and started a brand new antimicrobial agent.
Okay, so the formula is lungs got worse, plus systemic signs of infection, plus new antibiotic drugs. That equals an IVAC.
And then finally, at the very top of the specificity funnel, we have step 3, which is possible VAP. That requires an established IVAC plus a definitively positive microbiological culture drawn directly from the patient's respiratory tract.
Got it. So it's a tightening funnel. You start with worsening vent settings, you add the clinical infection signs, and then you add a specific bug growing in a petri dish. And this trial was explicitly designed to see if the highly engineered, fancy tube could stop patients from falling down that exact funnel.
Exactly. The core hypothesis was that the PU evac tube would significantly reduce the rate of these highly objective events compared to the cheap standard tube.
So, drum roll, please. Did the Cadillac tube actually save the day? Did it stop the infectious sludge from destroying the lungs?
The short, painful answer is no.
Oof, just a flat no. Nothing.
A completely flat, statistically resounding no. Let's look at the primary numbers they published. For the outcome of IVAs, that objective infection-related complication, the rate was exactly 8% in the fancy tube group and 6% in the standard PVC tube group.
Wait, 8% versus 6%? Well, first of all, that's clearly no statistical difference.
Yeah.
But if anything, the raw point estimate was actually higher in the expensive fancy tube group.
Yes. Statistically speaking, it's a total wash. The risk difference was not significant. The confidence interval crossed the null zero line perfectly. But yes, strictly looking at the raw point estimate, there is absolutely no signal of benefit whatsoever. If anything, it leans slightly the wrong way.
Wow. Okay, what about the fully confirmed pneumonia, the possible VAP with the positive cultures?
It's the exact same story there. 6% in the fancy PU evac group versus 5% in the standard PVC group. Again, absolutely no meaningful or statistically significant difference.
Okay, so it completely failed to prevent the strict infection definitions. But what about the downstream stuff that patients and, honestly, hospital administrators actually care about? Did they at least get off the ventilator faster? Did they leave the intensive care unit sooner?
No differences at all. Ventilator-free days were essentially identical. ICU length of stay was the same. Hospital length of stay was the same.
And what about antibiotics? We are constantly getting hammered by pharmacy about antimicrobial stewardship. Did we at least use fewer days of broad-spectrum drugs?
No difference there either. Approximately 73 to 74% of the patients in both groups ended up being placed on systemic antibiotics for at least 4 days during their run.
Wow. Just pause on that reality for a second. 3/4 of these emergency intubation patients are getting blasted with heavy antibiotics, regardless of what specific type of plastic is sitting in their trachea.
It is a very, very telling statistic about the sheer reality of modern critical care. But honestly, here is the specific number buried in the tables that really stopped me in my tracks when I first read the paper. The overall mortality.
Yeah, I saw this in Table 2 as well. It's incredibly sobering.
At 6 months out from the initial intubation event, the mortality rate in both study groups was approximately 50%.
Let that truly sink in for a minute. Half of the human beings who required an emergency intubation in this trial were dead within 6 months.
It really dramatically puts the entire two-choice debate into a very stark perspective, doesn't it? When you are actively dealing with a patient population that is profoundly sick people crashing from overwhelming sepsis, massive blunt trauma, prolonged cardiac arrest, severe primary pneumonia, the microscopic material of the endotracheal tube cuff is just completely drowned out by the overwhelming systemic noise of their primary disease process.
It's like trying to put out a raging 1,000-acre forest fire with a slightly better engineered water pistol. Sure, your water pistol might theoretically have better fluid dynamics than the cheap squirt gun, but the forest is still burning down around you. The sheer overwhelming severity of illness here is the absolute dominant factor dictating survival.
Exactly. And to be fair, the trial authors readily acknowledge this exact point in their discussion. In such a high mortality, high severity, unselected population, it is incredibly difficult for any single isolated device intervention to clearly show a mortality benefit. The signal-to-noise ratio is just too poor, but we have to remember, they didn't even show a morbidity benefit here. They didn't even successfully prevent the localized infections the device was literally engineered to prevent.
Right. So efficacy is just a complete bust.
Yeah.
The fancy, expensive tube didn't work any better than the cheap standard tube. Well, wait, it actually gets a little stickier when you read further down. We talked about efficacy. Does the tool actually work? But what about safety? Did the fancy tube actually do any tangible harm to these patients?
This is where we start to see a very concerning signal in the data. It wasn't the primary powered endpoint of the study, but it is undeniably there in the secondary analysis. They specifically looked at laryngeal injuries.
So we're talking about physical damage to the voice box. Symptoms like severe sore throat, profound hoarseness, trouble swallowing water or food.
Right. Among the specific patients who actually survived to the 6-month follow-up, and remember, that's a relatively small group because half of the original cohort died. Significant laryngeal injury was reported in 83% of the PU EVAC group compared to 70% of the standard PVC group.
Right, 83% versus 70%. That's a 13% absolute difference in physical throat damage. Was that statistically significant?
The calculated p-value for that specific comparison was 0.098. So in the strict, rigid language of pure statistics, no, it's not significant at the traditional 0.05 alpha level. But as a clinician and a researcher, I look at an absolute difference of 13% and I clearly see a safety signal. It strongly trends towards objective harm.
And if you stop and think about it biologically, it makes complete mechanistic sense, right? Let's just think about the physical dimensions of the device again. You have the standard circular tube, but then you have this extra rigid plastic lumen, the dedicated suction channel molded directly into the side of it.
Yes. That extra channel physically makes the overall tube slightly wider and arguably significantly stiffer. It's not a perfect flexible circle anymore. It's a bit oblong and rigid, and it's sitting there constantly rubbing against the incredibly delicate vocal cords and the posterior commissure of the larynx for days or weeks on end while the patient breathes and coughs.
Plus, you are actively applying continuous negative wall suction to that exact area.
Correct. Even strictly regulated at -20 millimeters of mercury, that continuous suction can physically pull the frail tracheal mucosa right into the evacuation port. It can cause what we mentioned earlier, suction trauma or mucosal involution.
It's basically like getting a mechanical hickey on the inside of your windpipe.
It is a very unpleasant but extremely accurate analogy for the pathophysiology, a continuous 24-hour-a-day hickey. If that delicate tissue gets repeatedly sucked in, bruised, and inflamed, that constitutes a physical mechanical injury. That causes massive local edema. That causes deep ulceration over time.
And for a survivor who is just trying to recover from a massive critical illness, having a severe, persistent sore throat or clinically significant dysphagia Real trouble swallowing their food safely is a huge, huge quality of life issue post-discharge.
Absolutely it is. If you miraculously survive a 3-week stint in the ICU for septic shock, but you go home and you can't eat solid food without violently choking because your swallowing mechanism is totally wrecked, that is a major catastrophic failure of our care process. It leads to aspiration, readmission, and severe depression.
So let's just clearly summarize the results of this massive trial so far. The highly expensive, highly engineered fancy tube did not reduce pneumonia rates. It did not reduce total antibiotic use. It definitely did not save any lives. And it quite possibly caused significantly more physical damage to the patient's throat.
That is definitely not a great sales pitch for the fancy tube.
It really is not. Honestly, it sounds like a total lemon of a device.
Now, I want to formally pivot to the editorial that came out alongside this trial, because the authors, Klumpus and Branson, really take a step back from the raw p-values and ask a profound philosophical question about our specialty. The title of their piece is Time to Pull the Plug on Subglottic Secretion Drainage.
It's a beautifully provocative title. I love it when journal editors let authors have a little fun.
It is great, and they fundamentally highlight a massive paradox in the field of critical care. We all universally acknowledge that mechanical ventilation is a life-saving intervention. You simply cannot survive acute, profound respiratory failure without it. But the paradox is that the machine itself is also inherently life-threatening.
Right. It causes VAP, it causes severe ARDS from pressure barotrauma, it causes the tracheal injury we just discussed. The ventilator is the devil we know, but it's still a devil.
And for decades now, our entire field has been completely obsessed with the specific metric of preventing VAP. We have complex nursing bundles, we have laminated checklists on every door, we have dedicated infection control surveillance teams. Hospitals literally get dinged financially by Medicare if their reported VAP rates are too high. But the editorial brilliantly argues that we might actually be chasing the completely wrong metric.
How so? Walk me through their logic.
Well, just look at the historical disconnect in the literature. Previous massive meta-analyses, those studies that pooled together dozens of smaller, older trials, strongly suggested that these specialized suction tubes do reliably reduce the incidence of VAP. But those exact same pooled studies rarely, if ever, showed a corresponding reduction in the actual duration of mechanical ventilation or overall patient mortality.
So effectively, we were just successfully fixing the number in the hospital's quality spreadsheet, the reported VAP rate, but we weren't actually changing the human patient's actual clinical journey at all.
Exactly. The editorial really hammers home the point that VAP, as traditionally defined by clinicians at the bedside, is a deeply subjective, incredibly messy diagnosis. Depending entirely on who is subjectively reading the morning x-ray, or exactly how aggressively you decide to hunt for bacteria with a bronchoscope, the official rate changes dramatically.
So if I rigorously intervene with a special tube that mechanically sucks out all the superficial secretions above the cuff, maybe I predictably get fewer positive sputum cultures from the lab. So on paper, my official VAP rate magically goes down. But if that exact same patient still has severely inflamed, injured lungs and still ends up dying of multi-system organ failure on day 14, did I actually help them? Or did I just treat the chart?
Precisely. If an expensive device intervention reliably lowers the subjective VAP rate, but fundamentally fails to lower total antibiotic days or ventilator days or survival, are you actually preventing real, meaningful disease? Or are you just temporarily preventing the administrative surveillance definition of that disease?
Man, that is a really deep, uncomfortable question for us to ask ourselves. It's exactly like teaching a kid purely to pass a standardized test. If we perfectly ace the VAP quality metric test, but the patient still spends 14 agonizing days on the vent and ultimately dies, we haven't actually accomplished anything of value for that human being.
And the editorial astutely points out that in PreVent, too, because the investigators specifically forced the use of these rigorous, ungameable CDC definitions, the VAC and the IVAC, which are purely objective because you either demonstrably increased the vent settings or you didn't, the supposed benefit of the fancy tube completely evaporated into thin air.
So the moment you strip away the human subjectivity and the clinical guesswork, the magic of the device just completely fades away.
Precisely. They also bring up a crucial epidemiological concept called baseline risk. In the control group of this new trial, the people who just got the cheap standard PDC tube, the absolute rate of possible VAP was only 5%.
That's remarkably low. I feel like 10 or 15 years ago, during my training, we routinely talked about expected VAP rates in the ICU of 15 or even 20%.
We definitely did. But the reality is that baseline standard ICU care has gotten exponentially better over the last decade. We religiously elevate the head of the bed for every patient. We perform daily spontaneous breathing trials. We aggressively minimize heavy sedation drips. We do incredibly rigorous oral care with chlorhexidine and suction toothbrushes. The modern standard of care prevention bundle is now so highly effective on its own that the baseline background rate of true pneumonia is already remarkably low.
It's the classic law of diminishing marginal returns. If your nursing staff is already doing a spectacularly great job with the fundamental basics of airway care, adding a $90 fancy plastic tube simply has way less mathematical room to make a clinically noticeable difference.
Exactly. To definitively show a statistical benefit when the background event rate is already hovering around a mere 5%, you would mathematically need a truly massive sample size, maybe 10,000 or 15,000 patients, or you would need a truly miraculous game-changing intervention. And the data clearly shows this specific tube is not miraculous.
So I want to quickly rewind the clock for a minute here. In the intro, we briefly mentioned the Deem-et-al. Pilot study from 2016. This was published in the Annals ATS. Why exactly are we dragging up a 9-year-old pilot study today?
Because it serves as a perfectly frustrating example of why we desperately need to pay attention to early pilot data and why, unfortunately, medical history constantly repeats itself.
Okay, tell us about the Deem pilot. What do they do?
It was essentially the direct prequel to the PreVent 2 trial. Much smaller scale. They only enrolled 102 patients total. But the core study design was remarkably similar. Unselected emergency intubations randomized into 3 separate arms. A polyurethane cuff alone, a polyurethane cuff plus continuous suction, they called it CAS, and finally, the standard PVC control.
And what did they find way back in 2016 with those 102 patients?
They found absolutely nothing. No statistically significant difference whatsoever in bacterial colonization of the deep trachea. No significant difference in clinical VAP rates.
So literally 9 years ago, we already had a very strong hint that this might be a totally dead end in the emergency setting.
We had a very strong hint. The pilot beautifully proved that the intervention itself was legally and logistically feasible. It proved you absolutely can successfully randomize in a chaotic emergency setting using the complex exception from informed consent rules, but the actual efficacy signal just wasn't there at all.
And yet, despite that negative pilot data, a massive number of hospital systems aggressively adopted these expensive tubes anyway as their default standard. Why does that happen?
Mostly because the core mechanical mechanism just makes so much intuitive sense to doctors and administrators. It physically feels like it should work. And to be fair, there were other contemporary studies, mostly in highly controlled elective surgical patients or very specific, narrow populations that were ostensibly positive. So the overwhelming enthusiasm for the biological plausibility simply overrode the actual hard data from the pilot study in the specific emergency setting.
And so PreVent 2 was basically just the massively expensive blockbuster Hollywood sequel to Deem 2016. They scaled the whole production up to over 1,000 patients, just to be absolutely 100% sure, and they just independently confirmed the exact same negative finding from the original script.
Well, yes, but that means science works. Even if the final published result is a boring null, it's a massive success for the scientific method. We now definitively, incontrovertibly know that in this specific unselected emergency population, this specific device intervention simply does not add value.
I totally agree it's good science. But I really want to dig a little deeper into the why. Why exactly did it fail to work at the bedside? We already touched on the low baseline risk and the overwhelming severity of illness drowning out the signal. But is there something mechanically else happening? Why didn't the ultra-thin polyurethane material seal better like the engineers promised?
That's a really fantastic physiological question. The entire engineering premise is that the polyurethane cuff creates this absolute perfect watertight seal. But think about the physical conditions during an actual emergency intubation.
Like I said earlier, it's total chaos, fluids everywhere.
Right. You are very often blindly grabbing a tube size based on a frantic split-second visual guess of the patient's height. You say, looks like a 7.5 might fit. You slide it in, and then you are inflating that delicate cuff incredibly rapidly with a random 10 cc plastic syringe. You certainly aren't carefully, meticulously measuring the exact inflation pressures with a calibrated analog manometer in that frantic first minute while you're trying to get a blood pressure.
And the patient is very often actively moving. They're coughing, they're bucking the vent, they're fighting the tube until the paralytic fully sets in. It's absolutely not a controlled, static environment.
Right. So it's highly possible that in the dynamic, violent chaos of a crash airway, the theoretical better seal of the delicate polyurethane cuff just isn't physically robust enough to actually matter. If the crashing patient violently vomits their entire stomach contents on induction, or if they already have massive, thick secretions pooling in their hypopharynx before the plastic tube ever even crosses the vocal cords, the game is arguably already lost before you start.
That perfectly brings up the concept we call the inoculum effect.
Exactly. Think about the strict timeline of an emergency. The patient actively seizes at home, or they massively aspirate during a code blue on the floor. The heavy bacterial load, the primary inoculum, forcefully enters the deep lower lobes of the lungs right then and there. You get paged, and you finally intubate them maybe 5, 10, or 20 minutes later.
The horse has already completely left the barn, ran down the street, and is in the next county.
Exactly. You can meticulously place the most expensive, fanciest, most perfectly sealed polyurethane tube in the entire world into their trachea after that massive aspiration event. But the structural damage is already done. The fulminant pneumonia that predictably develops 3 days later on the vent was already seated at the exact moment of their initial collapse. The subsequent choice of plastic tube is completely irrelevant to the development of that specific mnemonic process.
That makes so much physiological sense. We're essentially trying to use a fancy door seal to prevent a massive fire that's already actively smoldering in the basement.
And let's quickly talk about the physical suction port again. We already mentioned the mechanical clogging issues, but the accompanying editorial and the deep discussion section in the main paper also explicitly mention that the physical addition of the suction lumen fundamentally alters the mechanics of the tube. It makes the entire structure notably stiffer.
Yes, and this loops right back to the safety signal we highlighted earlier.
A thicker, stiffer tube physically sits very differently in the natural curve of the human airway. It might exert significantly more focal mechanical pressure on the delicate posterior glottis. And this brings us to a really vital epidemiological concept called competing risks.
Oh, I love this. Unpack competing risks for us.
Simply put, if a specific medical intervention has a tiny, entirely theoretical benefit, like maybe preventing a very microscopic amount of ongoing microaspiration, but it simultaneously carries a highly tangible, easily measurable physical harm, like causing severe mucosal injury, bleeding, or massive laryngeal edema, and the patient is highly likely to die of their underlying septic shock anyway. The clinical math just simply doesn't work out in favor of deploying the intervention.
You're essentially actively trading a completely hypothetical invisible gain for a very real, very painful fistral complication.
Exactly. And in all of medicine, first, do no harm is supposed to be our ultimate guiding principle. If the expensive device physically hurts the patient's throat, and we now know it definitely doesn't save their lungs or their life, it simply has no logical place in our emergency airway box.
Okay, so let's urgently bring all of this high-level data right back down to the actual bedside. I'm walking into the hospital for my night shift tomorrow. I do my checks, and I see the airway cart in the trauma bay. It currently has the expensive PU evac tubes fully stocked in every drawer. What exactly do I do?
Well, first off, do you immediately throw them all in the red biohazard bin? No. They are fully FDA-cleared devices. They are legally considered a standard of care option. They do fundamentally function perfectly fine as basic breathing tubes to deliver oxygen.
Right, we're definitely not saying that using one is medical malpractice. If you successfully used one on a patient yesterday, please don't panic or write an incident report.
No, not at all. But based purely on the rock-solid data from PreVent 2, if your hospital administration is desperately looking for safe ways to save money, and let's be totally honest, every single hospital right now is looking to cut costs intentionally. Switching back to stocking the cheap standard PVC tubes for your emergency crash carts is a highly evidence-based, totally defensible way to cut your supply budget.
It essentially moves from being a must-have standard to a nice-to-have luxury. Actually, you know what? Based on the laryngeal injury data, maybe it's not even a nice-to-have anymore.
I would actually strongly agree with that assessment. If I'm currently sitting as the medical director of a busy mixed ICU, I'm looking closely at this trial data, and I'm confidently saying to my committee, we do not need to financially mandate these expensive tubes for our unselected emergency intubations. We can absolutely save that budget line item for something that actually works.
Now, what about for a scheduled elective cardiac surgery? Or the specific neurotrauma patient we absolutely know definitively is going to be heavily sedated and intubated for at least 2 straight weeks?
That is a completely different patient population, and we have to be careful not to over-extrapolate. This specific trial exclusively looked at unselected emergency intubations. It is entirely possible, and honestly, some of the older, narrower data suggests that in a highly controlled OR setting for a very long surgical case, or in a patient with a perfectly clean, unsoiled airway where you have the luxury to place the tube gently and perfectly check the pressures, maybe the basic physics of the seal actually works there.
But for the messy, unpredictable crash airway in the ER or the floor, the gold standard data firmly says no.
The highest quality data we currently have says no.
And I think there is a really vital workflow and psychological takeaway here for the bedside team, too. If your unit does still use these fancy tubes, you have to be hyper-aware of falling into the false security trap.
Oh, totally. The psychological trap of thinking, well, I put the fancy suction tube in, so I really don't need to aggressively worry about VAP anymore. The magic tube is handling it for me.
Exactly. That is dead wrong. The trial definitively showed that even with the absolute bed, continuous suction tube perfectly placed, VAP still happens at the exact same rate. So you absolutely still need to fiercely execute the preventative bundle. You simply cannot outsource your meticulous nursing and respiratory care to a fancy piece of molded plastic.
So let's quickly review the boring, unsexy stuff that actually works to save lives.
Yeah.
The rigorous stuff that doesn't cost extra supply chain money, just extra clinical attention and effort.
Number 1 on the list?
Yeah.
Strict head of bed elevation.
30 to 45 degrees at all times, unless physically contraindicated by a spine issue. Gravity is your absolute best friend. Keep the acidic stomach contents down in the stomach where they belong.
Number 2, aggressive, meticulous oral care.
Yes. Physically brush their teeth. Physically remove the gross dental plaque and the biofilm gunk. The routine use of chlorhexidine is getting a bit controversial in some academic circles right now, but simple, thorough mechanical cleaning with a suction toothbrush is absolutely essential. Do not let the patient's mouth silently become a stagnant bacterial swamp.
Number 3, and arguably the most important, daily spontaneous breathing trials and sedation vacations.
This is the big one. Turn off the propofol. Wake them up. Let them breathe. Test their mechanics daily.
Because the ultimate foolproof VAP prevention strategy is extubation. You literally cannot get a ventilator-associated pneumonia if you do not have a ventilator tube in your throat.
Precisely. The absolute best tube is no tube at all. Focus all your clinical energy and unit resources on getting the plastic out of the patient, not debating which specific brand of plastic you initially put in.
And one more highly practical pearl from the study. Please, actually listen to your patients carefully after they get extubated.
Yes. This is a crucial bedside takeaway. If you know you used a subglottic suction tube during their run, and post-extubation the patient is persistently complaining of a uniquely severe sore throat, or their vocal quality is incredibly raspy and hoarse, or, and this is the massive red flag, if they're violently coughing every single time they try to sip water. Right. Don't just lazily brush it off and say, oh, you were intubated for a week. Of course it hurts. That's totally normal. Stop and specifically think about laryngeal injury. That stiff suction port might have actively caused severe physical trauma to their swallowing mechanics.
They might urgently need a formal swallowing evaluation by speech pathology before you just casually let them eat a full hamburger from the cafeteria.
Exactly. Because if you miss that subtle laryngeal injury and they massively aspirate their very first solid meal on the floor, you've literally just caused a whole new devastating aspiration pneumonia. You've actively created the exact horrific problem you were originally trying to prevent in the ICU.
So secure the tube like it owes you money, but maybe actively respect the larynx like it's your grandmother's fine china.
I really like that. That should be on a poster.
So looking back, we've covered the fundamental passivities, the massive trial design, the totally null efficacy results, and the really concerning safety signal. It strongly feels like a pretty definitive, evidence-based chapter closing on the universal, unquestioned use of these expensive tubes in the emergency setting.
I genuinely think so. It's a beautifully classic case study in medical de-implementation. We enthusiastically added something to our carts years ago because it just intuitively seemed like a really good idea. We finally tested it rigorously in the real world. It completely failed to hold up to the scrutiny. Now, as a specialty, we need to be intellectually brave enough to actually stop doing it, or at the very least, stop blindly paying a premium for it.
And maybe invest that saved budget money in hiring more bedside nurses.
Or hiring more respiratory therapists, because honestly, a highly skilled RT meticulously managing those cuff pressures and continuously performing deep oral suctioning is worth 10 times more to patient survival than any fancy piece of engineered plastic ever will be.
Amen to that. Remember, the ventilator isn't actually mad at you folks, it's just communicating loudly. And usually, it's the incredibly tired RT who has to translate it for us.
Before we officially wrap up the rounds, I just want to highlight one last really profound thought from the Columbus editorial. They explicitly ask the field, if we basically can't engineer our way out of VAP with better, tighter plastic cuffs, where exactly do we go next as a specialty?
That truly is the million-dollar research question. If the physical hardware solutions are completely maxed out, what's left for us to study?
The biology itself, the human microbiome.
Oh, explain that a bit more.
Well, maybe the future of critical care isn't about futilely trying to mechanically block all bacteria from ever entering the lower lungs, because as we just discussed with the inoculum effect, maybe that's actually physically impossible in a crashing patient. Maybe the next frontier is about chemically or biologically changing which specific bacteria are allowed to live there. Targeted probiotics, or maybe pharmacologically modulating the patient's own host immune response so the inevitable localized inflammation doesn't cause such massive systemic ARDS damage.
Or we just swing the pendulum back to purely process-based care, just aggressively getting better at the less is more philosophy of critical care, less deep sedation, less physical mobilization, less total time connected to the machine.
Exactly. We very well might have officially reached peak plastic and airway management. The next massive breakthrough in survival probably won't come off a manufacturing assembly line.
All right, let's firmly wrap this up with our 3 key takeaways for the listener. If you are walking into your shift and you only remember 3 specific things from this entire deep dive, what exactly should they be?
Bullet point 1 is the trial itself. PreVent 2, which is the largest rigorous RCT to date on this specific topic, definitively showed absolutely no difference in VAP, no difference in IVAC, no difference in total antibiotic use, and no difference in any clinical outcomes when routinely using polyurethane subglottic suction tubes in unselected emergency intubations.
Awesome. Bullet point 2 is the mortality context. Overall mortality in this specific unselected emergency population is incredibly stubbornly high, hovering right around 50% at 6 months out. The sheer overwhelming severity of the underlying disease process completely overshadows any minor choice of endotracheal tube material.
And finally, bullet point 3 is the safety signal. There is a very real, concerning statistical trend towards increased physical laryngeal injury and subsequent dysphagia with the stiffer, fancy tubes. Since the standard, cheap PVC tubes are significantly more cost-effective and seemingly much safer for the physical throat, they absolutely remain a completely defensible and arguably vastly superior standard of care for emergency crash airways.
Well, there you have it, folks. Do not feel guilty for a single second about reaching for the cheap tube. Focus your energy on the patient, not the plastic.
And, as always, please keep a very close eye on those cuff pressures.
Always. Keep your pressures up and your gradients down. Thank you so much for listening to this deep dive. We will see you out there on the next shift.
Goodbye, everyone.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.